this or you want to use a button?
I want to use a...
Up, laser. Left, right.
Okay. And it's not on?
If you move this mouse, this will get recorded.
Okay. I'm not going to touch it. I'm going to use it. Good morning, everybody. Welcome to your second calcium lecture, your first bone lecture. Before we start, I would like to ask everybody to take a moment of silence in recognition of today's date, September 11th. Okay. So we're going to talk about bone disease today, which is the second part of your lecture about calcium homeostasis. Really?
Yeah, because it's feedback.
So yesterday, you learned about calcium homeostasis in extent, and especially about the three major organ systems that are involved, namely the gut, the kidney, and the bone. So today, we're going to focus on the bone. We're going to start by talking about bone structure, the cells, and also the key molecules involved in bone physiology and pathology. We're going to focus on two important concepts in bone disease, modeling and remodeling. Then we're going to move on to talk about one of the most important and common diseases, osteoporosis. We're going to talk about its definition and epidemiology and impact in today's society and in future. We're going to then talk about diagnosis and screening of patients and also their treatment. And then very briefly, we're going to talk about osteomalacia and Paget's disease. So let's just start with talking about bone structure. So in every organ system that you want to learn about, the first thing to know is what is it made of. So bone is mainly made of matrix and mineral. The matrix is type 1 collagen fibrils, and the mineral is hydroxyapatite crystals and also amorphous calcium phosphate. The main cells involved in bone physiology, as you guys know, are osteoclasts, osteoblasts, and osteocytes. So everything starts with a mesenchymal cell, which then differentiates into an osteoblast. And this is under the control of an important pathway called the Wnt beta-catenin pathway. So I just want you to try and remember some of these names, not all of them, because there are a whole lot of molecules and pathways and everything involved. But this is actually a very important one. and try to remember it as being a good pathway. So Wnt beta-catenin pathway is involved in osteoblast formation and differentiation, and therefore in bone formation. So it's good. The more you have it, the more bone you're going to have. What does osteoblast do? Well, initially it starts laying down matrix, so those collagen fibrils, and then it starts the process of mineralization. The osteoblasts have different fates. Some of them just die after they finish doing what they're supposed to do. Some of them turn into osteocytes and get trapped inside the bone. And some of them turn into lining cells, which cover the bone surfaces. The main function of osteocyte is thought to be sensing of mechanical load. So let's say, for example, that you have a bone that has to be under a lot of mechanical stress, and it has to tolerate a lot of force. So ideally, that bone should be stronger, right? It should be thicker, it should have more mineral in it. And that's what the osteocyte does. It senses the amount of mechanical load on each given bone and promotes bone formation to make a stronger bone. On the other side of the equation, we have the hematopoietic stem cells. They differentiate into osteoclasts. What do osteoclasts do? They dissolve the bone mineral by secreting acid, mostly, and then they also dissolve the bone matrix by secreting different kinds of proteases. For example, cathepsin K. Now, in clinic, we can measure the breakdown of this bone matrix and the rate of breakdown of bone matrix by measuring the products of breakdown in the blood. So essentially, when the collagen is broken down by the osteoclast, there are little pieces of protein that are released inside the blood. They are called telopeptides, and we can measure them in clinic to see what's the rate of bone breakdown. Are we, facing a situation where we have a very, very rapid bone breakdown or a slow bone breakdown? The component that is checked in the blood is called CTX or C-telopeptide, and the one that is checked in the urine is called NTX or N-telopeptide. They're essentially the same thing. And we'll talk a little bit about how that becomes important in assessing an individual patient's risk of fracture. This is also an important molecule that I want you to try to remember. It's called rank ligand. Rank ligand is a surface molecule that is expressed on the surface of osteoblasts and also some other kinds of cells, but mostly osteoblasts. Rank ligand is the principal stimulator of osteoclast formation. So this is a very important concept, and you see that the activation of osteoclasts and the control of osteoclast function is at least partly under the influence and control of osteoblast. So there's a lot of crosstalk going on between these cells, and they control each other and they feed back into each other. How does that happen? There we go. So we have receptors on the surface of the progenitors and also on the surface of osteoclast itself, which is called rank. So it's kind of, obvious. Rank ligand is the ligand that attaches to rank. And when it does, it not only promotes the differentiation of hematopoietic progenitals into osteoclast, but also it activates the osteoclast and turns it into like a super osteoclast. They work more and they survive longer. Now, if there was only rank ligand and rank, you could imagine that after a while we would all turn into jellyfish, because there's something activating the osteoclast, and the osteoclast is just eating away at the bone, and there'd be no more bone left. But there is an innate molecule. I apologize, there should be an O here. It's called osteoprotegrin, OPG. This molecule is a soluble receptor for rank ligand. So it kind of scavenges some of the rank ligand and prevents it from attaching to its receptor on osteoclast. Before it has a chance to do it, it's taken out of the equation, and therefore you kind of like dial back down on the activity of your osteoclast and on your bone resorption. So there's a delicate balance going on between this osteoprotegrin and the rank and rank ligand system. And the balance determines whether you're forming bone or resorbing bone, and by the crosstalk between these cell lines, you hopefully get to a good steady state. So there is a lot of crosstalk, meaning that the osteoblast and osteoclast work very closely together. This process is called remodeling. Now, a couple of things that I want you to understand about remodeling is, first of all, it's a very regulated process, meaning that the osteoclast and the osteoblast work very closely together. What happens is that on a bone surface, this is like a quiet bone surface that is lined with bone lining cells. The osteoclasts will come in first by different mechanisms that trigger them. For example, if there is like a micro damage there, microfracture, and you need to have some repair mechanism. So the osteoclast comes in first and starts chewing away at the bone and making like a groove in it. And then the osteoclasts come in. These are the mononuclear cells that eventually differentiate into osteoblasts. So then the osteoblasts come in and they start building bone. And they kind of start like, filling up the hole that was dug by the osteoclast. So these two cells are coupled. That's very important, meaning that they work as a couple. One of them comes first and the other one comes afterwards and fills up the gap that has been created. Another important concept to remember is that modeling continues throughout life. As I mentioned, one of the most important functions of, did I say modeling? I meant remodeling. One of the important functions of remodeling is to repair damage. So, just wear and tear. You're walking around, you get little fractures and micro damage to your bone. There should be a mechanism to repair it, and this is the mechanism. And also, another function of bone, which you learned about yesterday, is the fact that bone really acts as a reservoir for calcium. If you have low calcium in your body, where do you get it from? You get it from bone. So this is how calcium is released into the bone. The osteoclast comes in, starts chewing away at the matrix and the mineral, and releases the calcium and the phosphate that you need into your bone. So these are the most important reasons why you need to have remodeling throughout the course of your life. Now, as opposed to that is the concept of modeling. What does modeling mean? Modeling just means making new bone. That happens when you're growing. When you're a child and you're growing up and you want to have like longer bones and bigger bones and stronger bones, that's called modeling. The difference is that modeling happens on a quiet surface. So you see that, those lining cells? Like imagine an osteoblast comes in and starts building more bone and more bone and more bone on top of it. That's called modeling. There is no osteoclast preparing the surface for the osteoblast first. But the remodeling, osteoclast comes in first. At any given time during a normal adult's life, about 90% of the bone surface in your whole body is quiet. It's covered by the lining cell and nothing is happening. About 10% of it is going through this process of remodeling. So the osteoclast comes in and starts digging in, and then the osteoblast comes in afterwards and starts repairing it. So important to remember, regulated, coupled, and happens throughout all your life. Now this is a photomicrograph of the actual process in real life. It's a bone biopsy. Excuse me. This blue area is the actual bone. In this particular staining, it comes out as blue. So you see the osteoclasts are here. Are these like big cells with a lot of nuclei? They are chewing away at the bone and starting to create this groove. And then the osteoblasts come afterwards and start filling the groove up. And you can see the material that the osteoblast has started to lay down. This is the osteoid. It's mainly type 1 collagen. So it's not bony yet. It's kind of like jelly. And then later on, you see this little flash of blue color that starts to appear in the osteoid. That's when the mineralization process starts. So for a period of time, in that new bone that is forming, it's really not bone, it's just jelly, and then it starts to mineralize. Okay. Takes several tries to flip through the slides, but anyway. So, you know, these are supposed to be coupled, and they work in a, the unit that they're working together is called the bone multicellular unit, or BMU. Some people call it bone metabolic unit. But, you know, as much as they try to work together and be like a good couple, nothing is perfect. So eventually what happens is that when the osteoclast chews away at the bone and the osteoblast comes in and wants to repair it, it doesn't repair it 100%. There's a little bit of defect that is left behind. So maybe it fills up the gap like 80%, 90%. There's a little bit of defect that is left behind. And that is why everybody will have a little bit of bone loss during the normal process of aging. Because every time you get one of these bone multicellular units trying to remodel your bone and trying to repair your micro damages, it doesn't happen 100%. There's a little bit of gap that is left behind. And you can imagine that if you have more and more and more of these bone multicellular units that are working all at the same time, then that teeny little bit of damage is going to accumulate over time. So the more remodeling that you have, the more defect you're going to have to end up with. Another key concept about bone is the different kinds of bone. What kinds of bone we have? We have two main kinds of bone. One of them is the cortical bone, which is the dense bone that is at the surface of the shaft of long bones. Most of our skeleton is composed of cortical bone. So it's about 80% of our skeleton, but only 3% turnover this every year. So it's not a very active bone, okay? It's kind of like a quiet bone, relatively. The other type of bone, which is in the center of bones, especially axial skeleton, like the vertebra and, you know, the pelvis, and like the hip joint, you know, around the center of the body. The bone that is in the center is called the cancellous bone or trabecular bone, and it has like a spongy, cushy appearance. This is also where bone marrow is, in the space between these spongy spaces. So trabecular bone is 20% of the skeleton, but a lot of turnover, 25% turnover each year. Now, why is this important? Let's say that you have a bone that has very high turnover, and then you have another bone that has very low turnover. If I give you a medication that stops turnover, which one is going to be affected more? The one that has high turnover. Imagine there are two streets, okay? One of them has a lot of traffic, the other one has a little traffic. If I block the street, which one is going to be affected more? The one that has more traffic, right? So you'll see, and I want you to remember this because it's going to help you later on when you try to learn about medication that we use for treating osteoporosis, that all of the medication used for treatment of osteoporosis that stop the remodeling process and stop the bone turnover are going to affect the cancellous bone more than the cortical bone. And we're going to see an example of this later, but this is a general principle, and you're going to see it over and over and over again. Any questions? Okay, so we're going to move on to my favorite topic, osteoporosis. After we finish this talk, I want you to look at every person that you see on the street with a stooped back, with a different eye, because it's very, very, very important. I want you to become passionate about understanding osteoporosis, diagnosing osteoporosis, and treating osteoporosis. Don't walk up to people on the street, okay? But, you know, kind of think about it. So this is the official description of osteoporosis by an NIH consensus from 2001, a skeletal disorder characterized by compromised bone strength, predisposing a person to an increased risk of fracture. And that's why we care about it, because of the increased risk of fracture. Now, this word here, bone strength, is a big word. What does that mean? Bone strength? How do I know if somebody has good bone strength or bad bone strength or no bone strength? Well, bone strength really depends on multiple things, but the two most important things is bone mass, how much bone you have. The more bone you have, the stronger it's going to be. And the other one is bone quality. So sometimes you might have a lot of bone, but it's just bad bone. There are lots of diseases that you end up having really dense and heavy bone, but of very poor quality because of defects in the microarchitecture. Unfortunately, in clinical practice today, we don't have any tool to routinely assess bone quality in every patient. You can't get a biopsy of every single 70-year-old woman who comes to your office with osteoporosis. So really, it's just a research concept at this point. And I want you to be familiar with it, but we can't assess it in office. So what we end up doing is we end up with just assessing the bone mass. So the bone quality, we can't do anything about it right now, can't assess it in every single patient. We're going to end up just looking at the bone mass and the bone density to try to determine if somebody has good bone strength or not. So just remember that this is not the whole story, but this is what we deal with. So what determines the bone mass? Obviously, if you achieved a good bone mass when you were growing as a child, you know, you're going to end up here. If you didn't achieve a good bone mass when you were a child, you're going to end up here. So you're going to start with a low bone mass in the beginning. Most of the bone mass is acquired during the first 3 decades of life. So by the time you're in your late 20s, that's it. You're not going to acquire any more bone. And 70 to 80% of it is determined by genetic factors. And this is why osteoporosis kind of runs in families, and you always ask for a family history from your patients. Because if your parents had low bone mass, you're kind of probably going to end up having low bone mass. An example of this, and there are many more, but just as an example, because we learned about this Wind pathway, so let's talk about it a little bit. So the Wind pathway, was it the good one or the bad one? Good one, yay, okay. So the Wind pathway, there are some genetic variations in molecules in the Wind pathway. It's called the pathway, so there's lots of molecules and lots of receptors. One of them is called the LRP5, which is the co-receptor. And it's been shown that if you have a genetic mutation in your LRP5 gene that makes it more active, you're going to have a higher bone mass. If you have a genetic variation that makes your LRP5 inactive, you're going to have a lower bone mass. It's a very simple example of how genetic plays a role. The other determinant of what your bone mass or your bone strength is going to be is the rate of bone loss later in life. So let's say two people have the same peak bone mass when they are 35 years old. And then one of them, for some reason, which we'll talk about some of them a little later, loses bone really, really, really rapidly. The other one loses bone very slowly. So by the time they're 60, the first one is going to have a lower bone mass, right? It's very obvious. A very common situation, as an example of this, is menopause. Women lose a lot of bone very quickly during the 10 years surrounding menopause. So 5 years before menopause to 5 years after menopause, women lose bone really rapidly. The normal rate of bone loss in a person who's just aging, just normal aging, is about 0.5 to 1% a year. In a woman who's going through menopause is 1 to 2% a year, so almost double. Which means that by the time a woman finishes her menopause, and that 10 years surrounding the menopause, they can potentially lose 10 to 20% of their bone mass. 10 to 20%. That's a lot. And that's why osteoporosis is more common in older women than in men. So this is a picture of a real normal bone and a real osteoporotic bone. So I want you to look at a bunch of things here. First of all, see that there are some horizontal structures, we call them plates, and some vertical structures, we call them rods. And look at the osteoporotic bone. You see few things. First of all, these plates, well, sort of, you know, can I even call this a plate? I don't know, it's like so thin. They get really, really thin. That's the first thing that happens in osteoporosis. And you know, you've heard maybe, like for layman terms, people call osteoporosis thinning bone. That's exactly what happens. And the other thing that happens is you see that some of these connections are almost lost. Look at this. It's like almost nothing holding these two pieces together. And look at this one. It's really nothing holding them together. So the connection is completely lost. And we think that this is why rapid bone loss is so important. And, well, important in a bad way. So imagine here that this plate is being chewed away by the osteoclasts, okay? But they're doing it really slowly, you know, very, very slowly. By the time they finish getting to this end, the osteoblasts are already in because they are coupled. They come in and they start repairing it. So, you know, you're going to end up with a plate that is a little bit thinner, but it's still there, right? Now, look at this one. If the osteoclasts are really, like, very enthusiastic and chewing away at the bone really quickly, by the time the osteoblast comes in, this is gone. What are they going to repair? They can't, you know, they can't lay down bone on air. So this is why rapid bone loss is an independent risk factor in determining who is likely to fracture and who's not. Because once these connections are lost, they are technically impossible to repair. This is a real biopsy of a normal bone and an osteoporotic bone. Is it difficult to imagine that this one is weaker than the other one? It's like nothing there. Nothing is connected to each other. So it's almost like a chair that you remove like a bunch of the legs or the connectors between the legs. Are you going to sit on it? No. It's going to break. And that's why the rate of bone loss is important, because of lost connections. Any questions? Okay. So, bone strength. Bone strength. How are we going to determine somebody's bone strength when they come in our office and we want to diagnose them with osteoporosis? We need a working definition of osteoporosis. And this was given to us by WHO in 1994, I think. So when you go to test your bone strength or your bone density or your bone mass, you get what is called a DEXA. It's a type of X-ray. We'll see a picture of it later. And the numbers that come out of this report are there are two numbers that come out. One of them is a T-score and the other one is a Z-score. What is a T-score? So the T-score compares that patient's bone mineral density with the average bone mineral density for normal young people of the same sex and same ethnicity. So you have a 70-year-old woman who's Caucasian. You send her to get a DEXA. They measure her bone mineral density with the X-ray. And they compare it with the average of young Caucasian females. So let's say a bunch of 30-year-olds. And then they express the difference in standard deviation. So they will tell you that this woman's bone mineral density is 2 standard deviations lower than the average of young, healthy 30-year-old females, Caucasian females. So her T-score will be -2. If it's higher, then the T-score will be plus 2. And based on this table, you can diagnose the patient with either normal bone density, if the T-score is -1 or above, osteoporosis, if the T-score is -2.5 or below, or low bone mass, if the T-score is between them. We used to use the term osteopenia, but we're kind of like moving away from it. Part of it is because people get confused. Osteoporosis, osteopenia, they don't know which one is which. And although osteopenia is important, it is technically, as per this definition, not a disease yet. So be very careful about labeling people with disease. It's important if you have a low bone density here, and you shouldn't let the patient go. You should evaluate them to see if they have any risk factors for fracture that might increase their risk on top of this T-score. There's a tool called FRAX, which we can talk about a little bit later if we have time. I didn't include it in the slides, but it's a kind of like a calculator that calculates your risk of fracture if you're in that category. So you technically don't have osteoporosis, but if you have a high risk with the FRAX calculator, you can still benefit from treatment. Oh, look at that. Okay, so the slide moved on. Another definition of osteoporosis, which we hope we don't have to use, but we will, is if you have a history of fragility fracture, then by definition you have osteoporosis. I don't care what your T-score is. What's a fragility fracture? If you have a fracture with a low or minimal trauma, which is trauma equal to or less than a fall from standing height. So sometimes that becomes very difficult. So a patient comes to you and tells you, you know what, I was walking and then my shopping cart was in front of me and then I tripped and I hit the door and then my shopping cart fell on top of me, da da da. How do you know what, like what? You know, it's very difficult to assess the force. But on the other hand, sometimes it's very easy. So if you have a patient who like woke up from sleep and sitting in bed and just slid off the bed and hit the floor and broke their pelvis, that's fragility fracture. You shouldn't break your pelvis when you slid off the bed. So that's very important. Don't let them go. Another way to look at osteoporosis is primary osteoporosis versus secondary osteoporosis. Primary osteoporosis is the osteoporosis that happens in postmenopausal women and in older women and men as part of normal aging, which now we know why, because you know those defects that stay behind, not completely repaired 100%. Secondary osteoporosis is due to specific diseases and can happen on top of primary osteoporosis. Then you'll be in really bad shape. For example, endocrine, which is our favorite subject, hyperthyroidism, which you've learned about, hyperparathyroidism, which you have also learned about, hypogonadism, and Cushing's syndrome. They can all cause additional osteoporosis and bone loss. Any disease of the GI system or any kind of malnutrition that leads to malabsorption of vitamin D and calcium. A lot of medication, most importantly steroids, a lot of people take them for different conditions. Anti-seizure medication interfere with vitamin D metabolism. And also excessive thyroid hormone replacement. Your patient has hypothyroidism, you give them medication, they took too much of it. Or your patient has thyroid cancer and you give them a little bit too much levothyroxine for a good reason. You know, you learned about treatment of thyroid cancer. We give them suppressive doses of levothyroxine on purpose. But that can also cause osteoporosis. It can be a contributing factor to osteoporosis. So you have to watch them, make sure they have adequate vitamin D, for example. And then, you know, there are a whole lot of other things. Alcoholism, rheumatoid arthritis, multiple myeloma, COPD. The list is very long. There are like big, big tables in every textbook about causes of secondary osteoporosis. And I just chose the most, you know, common ones and important ones. Now, after the next 3 slides, I want you to be really scared. Over 200 million people worldwide have osteoporosis. 10 million people in the US. 10 million. Okay. Each year, about 1.5 million people in the US suffer an osteoporotic fracture. At age 50, 1 of every 2 women is going to have a fracture in the rest of their life, in the remaining years of their life. 1 of every 2 women and 1 of every 5 men. Whole lot of men and women. 20% of elderly patients who suffer a hip fracture die within 1 year. 50% of survivors are unable to return to independent living. They end up in nursing homes. They can never go back to the same level of function that they had before they sustained the fracture. And we can do a whole lot better in treating these patients. Less than a quarter of patients who have a hip fracture ever get a bone density test. It's very cheap and very easily available, but they don't get it. Less than a quarter of them are even given calcium and vitamin D supplements. Really basic things. And less than 1/10 of them are given anti-resorptive medication, the main medication for treatment of osteoporosis. So we should really do a better job in identifying these patients and in treating them in a timely manner. What about the economic burden? Each year, about 500,000 hospital admissions because of osteoporotic fractures, 2.5 million medical office visits, and about 200,000 nursing home admissions because of osteoporotic fractures. What's the cost? And this is just the direct care cost. This is the cost of care of the patient. This doesn't include the cost of lost productivity of the patient or the lost productivity of people who have to take care of them because now they have to stay home, or their transport cost. This is just direct medical cost. $13.8 billion in 1995, $17 billion in 2005, and is projected to double by 2050, or triple. So this is the projected number of osteoporotic fractures worldwide. And you can see that in the US, this is just hip fracture. In the US, in 1990, there were about 358,000 cases of hip fracture. It's going to grow to double, 700,000 fractures by 2050. And look at what's going to happen in Asia. Asian women specifically are at a less risk of fracture as compared to Caucasians, for example. But because of the way the population is growing, the sheer number in 2050 is projected to be more than 3 million cases of hip fracture in Asia. Now, this slide, you're going to see these graphs one way or another in every single osteoporosis lecture that you're going to hear until the rest of your medical career, which is going to be a lot. So, bunch of things that I want you to remember from this slide. First, the most common type of osteoporotic fracture, both in men and in women, is radiographic vertebral fracture. What does that mean? It means a vertebral fracture that is diagnosed by a radiograph. So, meaning that it was probably asymptomatic. The patient didn't have pain. You know, they didn't go to the doctor. They got a chest x-ray 2 years later because of a cough. And then, whoops, you see a compressed vertebra somewhere in the chest x-ray. That is important. A lot of times it doesn't even get reported. There are studies that they pick chest x-rays from patients who were admitted to the hospital, and they give the chest x-rays to radiologists to read them again. And there's like 40–50% of these vertebral fractures are not even reported. But they are important, and you're going to see why. So those are the most common. Only about 1/3 of these vertebral fractures have any kind of symptom and cause pain and bring the patient to the doctor. But it's important when you identify them. Second thing is that, obviously, as we talked about it, you're going to increase the incidence of fractures with aging. So the older you get, the more fractures you're going to have of a different kind. Radiographic vertebral fracture, hip fracture, and wrist fracture, the 3 main kinds of osteoporotic fracture. You know, you can technically have, let's say, for example, rib fracture because of osteoporosis if you have like a low force trauma, but these are the 3 main ones that are reported in all the studies. And the last thing that I want you to see is that although the incidence of fracture increases with aging, it happens much earlier in women. It happens 10 years earlier in women. Can somebody say why? Because of menopause. Perfect. So because of the rapid bone loss surrounding menopause, women start losing bone earlier and faster, and therefore will start fracturing earlier and more. This is another way to look at it. So this is the probability of fracture by age with any given t-score. So if you have a t-score of minus 2.5 and you're 50-year-old versus your 80-year-old, the probability of fracture in an 80-year-old female with a t-score of minus 2.5 is 5 times higher than that of a 50-year-old with the same t-score. So it just gets worse and worse and worse. Age is a very, very important factor in determining risk of fracture. The first time I saw this slide, I was passing out. I couldn't believe it. This is the incidence of fracture compared to some diseases that we really care about that are on the news all the time, and there's like all kinds of like campaigns for defeating them, like cardiovascular disease and breast cancer. This is from the Women's Health Initiative Observational Study. It's about 90,000 postmenopausal women, followed for about 9 years. Look at the incidence of fracture in white women compared with invasive breast cancer, stroke and TIA, cardiovascular death, hip fracture, just a component of that one, of course, and all kinds of cardiovascular problems combined together. This is a composite endpoint. This, the white one, is CVD, including MI, coronary heart disease death, angina, CHF, DVT, coronary revascularization, TIA, a stroke, anything that can happen to your cardiovascular system, all of them on top of each other, it's still about half of number of fractures that these women get in the postmenopausal age. Can you believe that? Did you know that? It's unbelievable. It's the same in every race, Hispanic, African American, Indian, and Asian, except for blacks. In blacks, if you put all these cardiovascular endpoints together, it's a little bit higher than the incidence of fracture. But it's still important. Remember that we always think of osteoporosis as a disease of elderly white women. And therefore, when you see a black patient, an African American patient, or otherwise black race, you might not think about osteoporosis, but they might have it. It's to see, you know, see, there's a whole lot of fractures happening in them. So what ends up happening is that because we don't think about it, we don't treat them. So about only 10% of black patients who were admitted to a hospital with a hip fracture even received the diagnosis of osteoporosis. Nobody even thought about it. And from those people who actually received the diagnosis of osteoporosis, only 20% were discharged with medication. Because people don't think about it. We don't think of osteoporosis as a disease of African Americans. But now, of course, that's going to change. Why is having a fracture important? So you know what? You have a vertebral fracture. You have a little bit of pain in your back, and it goes away. And what's the big deal? The big deal is that it's a sign of things to come. If you have a vertebral fracture, this is a very busy table. Just focus on the 2 boxes that I'm showing you. If you have a vertebral fracture, you have a 4 times higher risk of having another vertebral fracture. And then another one, and then another one. The more that you have at baseline, the higher your risk is going to be. So before you know it, in a few years, you're going to have really severe kyphosis, you're going to have breathing problems, you're going to have digestive problems, et cetera, et cetera. And overall, if you have any kind of fracture at baseline, you are twice as likely to have any kind of fracture in follow-up. So one fracture is a golden opportunity to grab that patient and start treating them right away. Because this means that, you know, they're not done. They're going to fracture more. This is what happens. This is the natural course of osteoporosis. Well, the funny thing is that here, I mean, she's holding the umbrella and is avoiding the sun. And so then this is going to happen next, and then this is going to happen next. So how do we diagnose osteoporosis? With a X-ray test called dual energy X-ray absorptiometry, or DEXA. This is the kind of picture that you get. It gives you T-scores and bone mineral densities for every individual vertebra, and then an average of them. And this is the picture of the machine. It's actually very low X-ray exposure. It's about 1/10 of a chest X-ray, so it's very safe. Why is DEXA important? You know, we don't really care about tests so much. We care about outcomes. We don't care about the number on a DEXA. We care about the fracture. And this study from 1996 shows that DEXA actually translates into increased risk of fracture. So for every 1 standard deviation in bone density, so if the T-score is if my T-score is 1 standard deviation lower than yours, this is going to be my risk of fracture. If my T-score is 1 standard deviation lower in the hip, I'm going to have a 2.6 times higher risk of having a hip fracture. And overall, if you look at this part, the reduced T-score by 1 standard deviation in any site means that you're going to have 50% higher chance of fracture at any site. So if you have a low T-score in your forearm, it doesn't mean that you're just going to break your forearm. You can break your vertebra, you can break your hip. And that's why when you look at a DEXA score, I want you to pay attention to the lowest T-score. If the T-score is something in the forearm and something in the vertebra, but it's -3 in the hip, that's the one you're going to look at. So 1 break is enough. When someone has had a break, it's important to grab them then and start treating them. These are stuff that you would do for everybody. Adequate vitamin D intake, adequate calcium intake, weight-bearing exercises, avoiding use of tobacco, excessive alcohol, taking measures to avoid falls, and using of hip protectors, which are these like undergarments with cushions. I guess people probably don't really like them, but you know, if you have a really thin patient who falls frequently and you can't do really anything else about them, at least you can cushion them. So calcium, the current recommended daily allowance for women over 50 years is 1,200 milligrams. There are different components. You can use calcium carbonate, you can use calcium citrate. Some of them are cheaper, some of them are more expensive. Calcium citrate doesn't need stomach acid, so if somebody's taking medication to reduce stomach acid, you should give them calcium citrate. And you can't absorb more than 500 milligrams in a dose. So if you want to give all of that as a supplement, you should break it down into 2 pills. If they're drinking 2 glasses of milk a day, fine, just give them 1 pill. Vitamin D, unfortunately, is not very available in natural food products. It's only in water fish, and in some of the cereals and stuff are fortified with vitamin D, but otherwise it's not really available. So a lot of people need to take additional vitamin D, especially in areas like New York, in Northeast United States, in certain latitude, in states that are north of Missouri. Even if you are exposed to sun, because of the angle and the blah, 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 you don't really make enough vitamin D in your skin, especially if you have dark skin, especially if you're old. The National Osteoporosis Foundation recommendation is 800 to 1,000 units a day. You can give up to 4,000 units a day of vitamin D to your patient. That's a safe upper limit. And the currently accepted lower limit of normal in the blood, if you check your patient to see whether they have vitamin D deficiency or not, is 30 nanograms per ml. There's a lot of debate, 20 versus 30, but really 30 is the number. So this is a table of all the medication that are approved in the United States for treatment of osteoporosis. I am not going to ask you to remember all of this, don't worry. Except for this last one, all of these are anti-resorptives. So they work on the osteoclast, and they stop the osteoclast from resorbing bone. These 4 are bisphosphonates, And this teriparatide is the only medication that is anabolic, that actually makes you make bone. The other ones just prevent you from breaking bone. How do you choose the medication? You really should choose it based on the proven efficacy of preventing fracture. All of them prevent vertebral fracture, but not all of them prevent hip fracture. So if you have a patient who broke her left hip 1 month ago and you want to give them something to prevent breaking the right hip, you shouldn't give them calcitonin. These tables are available everywhere, so, and I mean, it's in your slide too. But essentially, you should choose a medication based on proven efficacy. The bisphosphonates are our first line of treatment for osteoporosis. They bind avidly to bone, so they have a long half-life. Even if you stop it, they're going to stay there for a few months or maybe a few years. And as I mentioned, they stop the osteoclast from resorbing bone. You tell the patient to take it first thing in the morning with a full glass of water. Don't lie down, because if they do, it might cause esophagitis, erosion of the esophagus. And if somebody has a lot of GI complaints and GI issues, you should probably use it with caution or maybe even stay away from it. And you can't give it to people who have kidney disease. Now, this is just an example of like a bazillion studies that is out there about bisphosphonates. And I just want you to be able to understand the principles. Usually, they will compare the rate of vertebral fracture, and this morphometric means the ones that they diagnose by X-ray, in a bunch of people who are on placebo and a bunch of people who are on the active medication. And you see, for example, for this zoledronic acid, which is the IV form, there was a 70% risk reduction of new vertebral fracture at the end of 3 years. So they are very potent, very effective. And they also look at a whole lot of other things like hip fracture, non-vertebral fracture, clinical vertebral fracture, meaning the ones that cause pain. And what I want you to just look at is just see how these lines are different. The ones who are on zoledronic acid always end up having less fracture than the ones who are not. There are 2 very feared side effects of using bisphosphonate: osteonecrosis of the jaw and atypical fractures. And I want you to remember a couple of things about them. The most important one is that they are very rare. They are hyped up a lot in the media and, in the TV, and they're like ads and, if you have taken this medication. But they are very rare. In people who take bisphosphonates for treatment of osteoporosis, the rate is less than 1 in 100,000 patients. So this is a funny slide. I love it. And I have 2 different versions of it. This is the risk of developing osteonecrosis of the jaw in someone who's taking bisphosphonates for osteoporosis compared with death from motor vehicle accident. Are you going to stay home, not go out because you can die? No. So the risk is very small. And also remember that it's not a fatal disease. Whereas if you have a hip fracture, you have a 20% chance of dying. So if you have a good indication for prescribing the medication, the risk versus benefit is actually, not bad. It's still to the benefit of the patient. Same thing with atypical fractures. The atypical fractures are like these horizontal fractures in the shaft of femur. They are also very rare in patients who take bisphosphonates for osteoporosis. And they usually have some kind of prodromal sign. So the patient comes in with pain, which should be taken seriously. If you have a high clinical suspicion, you're going to send the patient to get X-rays from their hips, or MRIs, or bone scans. Do whatever you want. But the risk is low. Inform your patient, and just be aware that for every case, you need to give bisphosphonate to 2,000 patients to cause one of these, whereas the number needed to treat for bisphosphonates is usually in the 30-40 range. So you give bisphosphonates to 30-40 patients. You prevent 1 osteoporotic fracture, but you need to give it to 2,000 patients to cause any of these. Another medication that I just want to briefly want you to hear about is denosumab, or Prolia. Do you remember the rank and rank ligand, which were the bad ones? We would turn into jellyfish. So denosumab is an antibody to rank ligand. And in this trial, in 2009, they randomized about 8,000 women to take denosumab versus placebo. And there was a 68% risk reduction in the risk of vertebral fracture. And also, you know, a lot of good risk reduction in every other endpoint too. You can see all the p-values are significant. Other medications, you know, we don't really use them that much anymore because bisphosphonates are the first line of treatment. They're very effective. So you would think about them in like really special situations. For example, raloxifene, which is a selective estrogen receptor modulator. It has estrogen-like effects in some organs, like the bone, and it has anti-estrogen effects on some other organs. It also reduces the risk of breast cancer, so you might give it to someone who is at increased risk of breast cancer. Calcitonin we really don't use anymore. It can be used for relieving pain in someone who has vertebral fracture, and teriparatide, which is a recombinant human PTH, is the only one that is actually anabolic and makes you make bone. Placebos don't work, and medications don't work if you don't take them. Osteoporosis is a silent disease, so a lot of patients stop taking the medication after 3 to 4 months. They're like, you know, I feel fine. So you should reevaluate them every time you see them, and you should make sure that they're actually taking their medication. Otherwise, it's not going to work. So let's switch over and talk really quickly about osteomalacia. So osteomalacia is a defective mineralization of the bone. If it happens in the same defective mineralization, if it happens in children, we call it rickets. If it happens in adults, we call it osteomalacia. And you can see this is the osteoid. Remember I told you that 90% of the bone surface is quiet at any time? So this is the normal person. You can see there's only a little bit of osteoid. But this is the osteomalacia patient that has a lot of osteoids. So there's a lot of bone formation going on. It's just that it doesn't mineralize. Who can tell me which one is osteoporosis? Right or left? Right, excellent. So the bone is gone. In osteomalacia, it's not gone. It's just not mineralized. It's like cushy and jelly. Many different causes. I'm not going to go over this for the sake of time. An interesting phenomena is the one that happens because of loss of phosphorus in the urine. So these patients come in with bone pain, and you end up finding out that they have low phosphorus in their blood, and it's because of this compound, which is called FGF22, and it causes you to lose phosphorus in your urine. You can have a lot of FGF23 because of a tumor, or because of genetic problems. You can't break your FGF23, so it just ends up accumulating in your blood. This is a recent case report in New England Journal from 2 weeks ago. It's a girl that has biliary disease, so ended up having malabsorption of vitamin D. And you can see the manifestations are very drastic in children. In adults, it's not like that. It's just like a little bit of bone pain and a little bit of muscle weakness. And how do you diagnose osteomalacia and how you treat it? It really depends on the underlying condition. So if they have vitamin D deficiency, you give them vitamin D. If they have a lot of phosphorus going out in their urine because of a tumor that is secreting a lot of FGF23, you have to find the tumor and remove it. Sometimes it's not very easy. And if you have the other kind of congenital forms or genetic forms of loss of phosphorus in your urine, you're going to have to end up giving them a lot of phosphate and vitamin D. And just a few words about Paget's disease. So Paget's disease is a focal area of increased bone remodeling. So essentially, in some parts of the skeleton, and it's usually in the axial skeleton, the osteoclasts go crazy. You know, they just chew away at the bone. And then the osteoblasts come in and they try to fix it, but it's just happening so quickly that the bone that they lay down end up being really disorganized. So instead of those nice lamella of collagen, it's like completely crazy, disorganized. It's usually a disease of the elderly, usually an incidental diagnosis. You find it on an X-ray or in a blood test, and then you end up finding out that the patient has Paget's disease. And some patients have bone pain, and that's one of the indications of starting them on treatment. As I mentioned, it's mostly found in the axial skeleton. You can see it in X-rays, different types of incomplete or complete fracture, and you can also see increased bone activity in bone scan. Different complications, including fracture, osteosarcoma, which is rare, high output cardiac failure, and hypercalcemia of immobilization, because there's so much turnover. Once these patients are immobilized, suddenly all the calcium is in the blood, and they become hypercalcemic. So if you have a disease with high bone turnover, how do you treat it? You give it medication that decreases the bone turnover. And what are the best example of these medications that we use these days is bisphosphonates. You're going to have to watch these patients for hypocalcemia if you start them on a bisphosphonate, though. Any questions? I'm sorry that I rushed through the last few slides. Dr. Epstein was flagging me from the back of the room. So I hope that if, obviously you can ask any questions at any time, but we will have a little bit more opportunity to discuss them in small groups. Okay, thank you.